Hello, everybody. Welcome back to the Incubator Podcast at CHNC 2024. We are back and joined by Dr. Rochelle Gomes and Dr. Alyssa Blumenfeld. Guys, welcome to the Incubator.
Thank you for having me.
So, you both have posters, and so you're attending, you're listening to the talks, and you're presenting later today?
Yes.
All right. So, you both have interests in neurodevelopment. You both have interest in early diagnosis of neurodevelopmental disorder, specifically autism spectrum disorder. So can you tell us a little bit about your interest and maybe how your interest translated into the work you're presenting today?
Sure. So my mother was a preschool teacher growing up. And so I always grew up working with kids with special needs. That's where her passion fell, was working with those kids who had a little more challenge. And I actually vividly remember her teaching a child who was an X24-weeker, who was nonverbal, had autism, and seeing how special he was in terms of how he interacted with the world was something that always landed with me. And so I actually went into medicine to care for children with special needs. That was very important to me. And I ended up in the NICU, loved surgery, loved ICU care. And so it was a perfect balance of being able to really impact children with special needs from the beginning. And so my interest really spans into how do we talk to families about this? How do we identify risk factors, and how can we improve care? Because in my mind, at the end of the day, what kind of life is my child going to live is really the important question for many, many parents.
Yeah, and for parents, like, the NICU is only one little step into the continuum of what is life. And for us, this is basically all of our time. But for them, this only represents a small fraction of what their child's life is going to be. So that makes absolute sense. What about you, Rochelle?
I think there's many different reasons for me to be interested in this area. The science behind autism, I feel like, is not well understood. We know the incidence prevalence is going up, whether it's because there is like biological basis to it or just we're diagnosing it more, we don't know. But with our NICU babies surviving, I feel like there must be something, or there might be something there that we haven't discovered yet. The other really big need I've recognized is with the community, with families that are caring for children with special needs, including autism. I don't feel like as medical professionals, we understand the life well enough. I don't feel like we understand their needs well enough. We tend to put them in little boxes of diagnoses, symptoms, and signs, but really they're people with hopes and dreams. And so it's very early days for me, but I hope to learn and grow both, I think, as a physician, but also as just somebody in the community in order to make, meaningful difference.
And we were all talking about this kind of off air, that sometimes NEOs are like, well, why do I need to know about autism? Why do I need to know about the neurodevelopmental disorders? But the parents are asking about it really from day one.
Bring a mic closer.
They're inquiring about it. I think for whatever reason, some of those words and concepts are more familiar to them than these new diagnoses we're throwing at them. So maybe you guys can speak a little bit to why you think it's important for neonatologists to pay attention to these things.
Sure. So autism prevalence in the population is 2 to 5%. In premature infants, it's more like 7 to 13%. So we know that there's something related to being premature that increases the risk. And it's not just those preemies. The population I've looked at as a fellow includes children who've been on ECMO, children with HIE, all of these other conditions that we see in the NICU. And I hope to eventually kind of suss out more of those risk factors. But I think at the end of the day, what's important to parents should be important to us, right? That's so much of what we do is forming relationships and helping them through this process. And how do we transition these families, exactly like you're saying, from the NICU, from this specific stage of life into the outside world, and help them get there without a sense of whiplash or a sense of fear or feeling alone and unsupported is really important.
Yeah. I think one of the biggest roles for neonatologists is empowering families, both with knowledge, with acceptance, and with resources. Because when you start very early telling a family that, your child has made it this far and has done all of these amazing things, but the road ahead is difficult in terms of growth, development. But we had that first opportunity to turn this message into a message of hope and strength and courage.
So interesting.
And I hope that, if more people understand that this is not something to fear, like to have a child with special needs, it is something that can add so much value to your life. It is hard for sure, but as physicians, especially the first physicians to meet these families, I think if you are able to give them a message of power rather than a message of fear, it will go a long way helping these families cope with what lies ahead.
Focusing on ability rather than
something
ability and what you can do.
Yes.
Something that Annie Janvier talked to us about at the TEDx conference. So look out for that talk. What do you guys think about what this says about neonatologists and physicians having to discuss something with families that we don't fully understand, something that we're not fully comfortable? This is not RDS that we feel like we've mastered in terms of pathophysiology, treatment, and so on. And I feel like the gaps in knowledge, which are present at baseline, plus the gaps in our knowledge of what we don't know, makes these conversations very scary. And so how do we cross that bridge and get closer to being able to provide meaningful counseling and advice to families in the NICUs about these topics?
I think first with humility, as always. I mean, that comes even for RDS.
That's true.
Right?
That is so true.
Right. So with humility. But if we don't know, that also means that there is hope.
Yeah.
There's hope. And our kids, I'm sure you've seen this as well. The children you see in your follow-up clinic, they defy
That's right.
odds. And the difference comes from, I think, the families that know what to expect, that are coping well, that have access to resources, and funds, like a lot of times. But so from the very beginning, I think sharing the message that we're sorry, this is difficult, like we understand, we're here for you, you can do this, it is going to be okay.
Mm-hmm. I try to focus. I think about it the same way we talk about delivering bad news, right? In terms of giving families the information, but also empowering them with some degree of hope. I think I emphasize that uncertainty when I talk to families, and that I can tell you there's a risk. I can tell you I'm seeing these things, but every bit of that is a piece of the puzzle. And you as a parent, you as a family unit are just as important in how these children do long term. And I agree. I see kids all the time where you don't expect them to do what they can do. And so emphasizing that children are so resilient, babies are so resilient, and there's really so much they can do, and that there is a community out there that is going to support you, and we are going to help you through this is the key.
And my counterpoint to my colleague is that there are plenty of things in neonatology that we discuss with families with such,
Certainty.
that we really don't know. The PDA, BPD.
Right. But I think that in this specific case, it is quite striking and it's terrifying because parents expect you to know because you're the physician, you're supposed to know. And the amount of what we know is so minuscule compared to what we don't know that it feels like, how can I be useful in this conversation when I really have no clue? And it feels like it's just basically the luck of the draw. That I think is what scares a lot of people from just even talking to families about it.
Well, then that's why you guys are here presenting your posters today, so that we are better educated, so we can have those conversations with families. So tell us about what each of you are presenting.
Sure. So I am presenting, I have a 2-part fellowship project. So the first part, we looked at retrospectively all of the children within our follow-up program at Emory and Children's Healthcare of Atlanta, which actually encompasses most of the state of Georgia. And we looked at risk factors associated with autism. So all of the babies that were referred for autism concerns, and looked at those, and then took a step further than that, and implemented a quality improvement project within our follow-up clinic, trying to decrease the age at autism diagnosis. So we've had a few different PDSA cycles. We've used kind of your classic QI methodology. And that's been the bulk of my fellowship project. And what we found is that, at least so far, the initiatives we've implemented have continued to decrease the age of diagnosis. And there's still more data to continue to be looked at. But we know that early diagnosis and early intervention not only gives parents a sense of, I know what's going on, or a sense of hope, but also improves outcomes. And we have the data to show that.
And what intervention has had the most effect?
Sure. So I think it's the combination of all of them. Essentially, the first thing we did was standardize our clinic schedule so that our families are coming at set specific times and getting the same testing across the cohort of all the patients at each time point. The second intervention was we actually partnered with the Marcus Autism Center in Atlanta to have our own clinic location at Marcus,
Wow.
which puts us in obvious closer proximity to autism resources and new innovation, like the eye tracking software that they just launched as well, early point. And then the third step was an implementation of a standardized screener within clinic, which looks at not just autism actually, but all different behavioral challenges that our patients have. But that's further decreased the age. We hope that's the data that's still in.
What about you, Rochelle?
So I won't talk about the one I'm presenting because it's not related to this, but there is something I'm working on. I want to talk about MCHAT scoring. MCHAT scoring is still, I feel like, underutilized. And so in our neurodevelopment clinic, we're trying to do a QI to see, can we enforce and can we track MCHAT scores in NICU graduates specifically and see what we find. I do think that something to be aware about is in children that have developmental delay, not related to autism, you will get a lot of false positives.
Right.
But there is a built-in mechanism by which you can try to screen out, is this really autism or is just delay? And so my message really to anyone that's hearing this that's related to pediatrics or has little children, please utilize the MCHAT. Like, it is very evidence-based, it's fairly easy, and it's something that we really should try to do between 18 months and 2.5 years to try to get a good population that can then be referred for early diagnosis.
I love that. So we're going to let you do your call to action for MCHAT and tell us about your poster.
Oh, sure. That time?
Yeah.
Okay. So my poster is also sort of, it is patient-centered, family-centered care that has to do with babies that are going home from the NICU with a gastrostomy tube. And so what I had realized when I started my, job as an attending is that the way we taught families how to take care of their babies with our G-tubes was kind of haphazard, and it was
Totally.
every provider had like a slightly different style, every nurse had a slightly different style, and I thought that it was going to cause a lot of confusion for parents, and there were holes in things that were not, being taught.
Yeah.
So I sat down with our surgeons, nurses, nurse practitioners, and then our NICU, core attendings as well, and came up with initially identifying what we thought our problems were. And a lack of like a standardized process or standardized information that we were giving the parents. That was one of the most important problems. Then we also identified that a lot of our families had language barriers or difficulty coming and staying in the hospital just due to, adverse social determinants.
Yeah. Other commitments, whatever they are.
Right? And so we then created this bundle through multiple PDSA cycles that involves, so initially the surgery team meets with them, talks to them about why your child needs a G-tube. Then they do training with the doll, then their G-tube happens. Then nursing takes over and does education in terms of G-tube cares. And then finally, the provider at the very end will review complications and what to do in case of G-tube coming out, G-tube getting blocked. We also used a parent questionnaire after they went home to try to see, so how did you feel about your GT ventilation? What is interesting is I feel like maybe because our numbers are small, there's no direct correlation. There are parents that tend to be confident. There are parents that tend to be nervous. I feel like even if you've checked off everything on that education, that's not unusual.
Maybe that's the information, is that those forms post discharge may not be as reliable and more reflective of the parents' perspective on their ability.
Yeah.
More of the Dunning-Kruger effect than anything else.
So I think especially when you have like such a small, sample size. So our unit is not big, but it's been I think for me as an early career neonatologist was one of the first projects that I took a lead on that was like multidisciplinary and learned one of the big pieces.
It involves surgeons.
The surgeons were not the hardest part. I have only gratitude for our surgeons and the surgery team that actually have invested a lot of time and has come through with, whatever.
Well, that probably saves them the most time on the back end when the parents know the most about going home with the tube.
So, yeah, it's been good. I've enjoyed it.
Yeah. Rochelle, Lisa, thank you so much for dropping by and sharing your work with us.
Thank you.
Thank you
so much
for having us.